Hi, my name is Catherine Varner. I'm an emergency physician and clinician scientist at Mount Sinai Hospital in Toronto, Ontario, Canada, and today I'm presenting the results of our study entitled A Randomized Control Trial Comparing Light Exercise to Standard Management for Mild Traumatic Brain Injury. My co-authors and I have no conflicts of interest to disclose. I'm currently funded by the University of Toronto Department of Family and Community Medicine, as well as the Schwartz-Reisman Emergency Medicine Institute at Mount Sinai Hospital. Funding for this trial was provided by the Workers' Safety and Insurance Board of Ontario, as well as the Canadian Association of Emergency Physicians. The emergency department is the first point of healthcare contact for most head-injured patients, yet the majority of these patients will not have an intracranial injury but will ultimately be diagnosed with a mild traumatic brain injury, also known as concussion. Most patients will have a full symptom recovery within 7 days. However, 15 to 30% will go on to develop post-concussion syndrome. Post-concussion syndrome usually peaks at around 4 to 6 weeks after injury, but upwards of 20% of patients will not have returned to work at a year after their initial visit from the emergency department. Current treatment recommendations for mild traumatic brain injury are cognitive rest and graduated return to usual activities, which includes exercise. The central dogma regarding exercise for mild traumatic brain injury is when in doubt, sit it out, or rest is best, meaning that patients are instructed to not return to exercise until their symptoms have abated. However, emerging data suggests that exercise may actually have favorable effects on the injured brain, especially if initiated in the early days following injury. The objective of our study was to determine if adult patients presenting to the emergency department with a discharge diagnosis of acute mild traumatic brain injury prescribed light exercise are less likely to develop post-concussion syndrome at 30 days compared to standard discharge instructions. This was a multi-center randomized control trial conducted in 3 academic tertiary care emergency departments in the province of Ontario, Canada: Mount Sinai Hospital in Toronto, Hamilton General and Hamilton Juravinski Hospitals in Hamilton are all academic hospitals affiliated with the University of Toronto and McMaster University, respectively. The annual visits at these sites are between 45,000 and 65,000 visits. The trial was registered with clinicaltrials.gov and ethics approval was received from each of the institutions. All adult patients presenting to the emergency department with a mild traumatic brain injury sustained within the preceding 48 hours were eligible for trial enrollment. Acute mild traumatic brain injury was defined by the Zurich Consensus Statement. Exclusion criteria are listed here. Diagnosis of mild traumatic brain injury and determination of trial eligibility were by the attending emergency physician. Informed written consent was obtained from trained research personnel when they were available, or by the attending physician or nurse if it was out of hours. Using one-to-one allocation, block sizes of 4, and sealed sequential envelopes, participants were randomized to either discharge instructions prescribing 30 minutes of light exercise daily, or discharge instructions describing graduated return to usual activities and cognitive rest. Discharge instructions were read by the attending physician or treating nurse. Patients were also given a printed copy of the discharge instructions. They were adapted from the Ontario Neurotrauma Foundation guidelines on the management of mild traumatic brain injury. The control group received instructions describing a graduated return to usual activities plan based on head injury symptoms and emphasized cognitive rest. Specifically, participants were instructed not to return to exercise until symptoms had resolved or advised to do so by a medical provider. The intervention group received the same graduated return to usual activity instructions with specific instructions to participate in 30 minutes of light exercise after a period of relative rest of 48 hours after the injury. The intervention group also received a written exercise prescription like the one shown for 30 minutes of light exercise daily, signed by their attending physician. The primary outcome was the proportion of patients with post-concussion syndrome defined as the presence of 3 or more moderate symptoms on the Rivermead Post-Concussion Symptoms Questionnaire at 30 days. The analysis of the trial was all very straightforward. Descriptive statistics were summarized using means with standard deviations, medians with interquartile ranges, or frequencies with 95% confidence intervals were appropriate. Proportional differences of PCS between groups were assessed using Pearson chi-square statistics. Differences in RPQ at 7, 14, and 30 days post-ED visit between the intervention and control groups were compared using paired sample t-tests. Based on prior studies, we predicted 30% of the control group would have PCS at 30 days. Assuming an alpha of 0.05 and beta of 0.2 to detect a 15% absolute risk difference, we estimated that 236 participants needed to be enrolled to reject the null hypothesis that the proportion of patients with PCS was not different in the two groups. To account for potential attrition, we increased the sample size by 25% and planned study enrollment for 296 patients, 148 in each group. No interim analysis was planned or conducted. The recruitment period was from July 2017 to October 2019, and the study ended when the target sample size was met after accounting for study attrition and all participant follow-ups were completed. A total of 367 patients were enrolled in the study. 184 were randomized to the control group and 183 to the intervention group. Median age was 32 years, and 57.6% were female. Patient demographic and clinical characteristics between groups were similar, with the only notable differences being incidence of a direct impact injury and being under the influence of drugs and alcohol at the time of injury. Clinical characteristics such as history of headaches, depression, and concussion were also similar between groups. This cohort also had high rates of mental illness, drug, and alcohol use. Overall, baseline median RPQ score was 15, which corresponds to moderate head injury symptoms. At ED presentation, median pain scores were 5 on the visual analog scale, and 85% of participants reported headache at the time of their ED assessment. The main finding of this trial was that there was no difference in the proportion of patients with post-concussion syndrome at 30 days. 13.4% of the control group and 14.6% of the intervention group met diagnostic criteria for PCS at 30 days, but this was a non-significant difference. There were also no differences in secondary clinical outcomes. There were no differences in median change of the RPQ scores, median number of return visits to a healthcare provider, median number of missed school or work days, or unplanned return visits to the ED within 30 days. However, it is important to note that participants in the control group reported fewer minutes of light exercise at 7 days, and this was a relationship that persisted at 14 and at 30 days. Fewer participants in the control group also reported participating in any physical activity within 7 days, but this trend did not persist at 14 and 30 days. We recognize our study has several limitations. First, the study was conducted in a small number of study sites that were all urban academically affiliated and Canadian, which may impact the generalizability of the results. There were also high rates of attrition, but both groups were equally affected. In addition, the average patient enrolled in our study presented with moderate head injury symptoms, potentially suggesting we enrolled lower acuity MTBI patients. Patients were also not blinded to treatment, thus intervention bias is possible. Additionally, patients may have sought medical attention from other healthcare providers or other self-treatment sources and received different advice, which may have altered their physical activity. Finally, the primary outcome measure used was RPQ, which is a self-reported subjective measure of symptoms following MTBI. To our knowledge, this is the first randomized trial of prescribed early light exercise for adults with acute mild traumatic brain injury. In the trial, there were no between-group differences in recovery or healthcare utilization outcomes. This exercise prescription was simple. It was not harmful for this patient population, and it has demonstrated efficacy in other injury patient populations. So we believe, based on this, an exercise prescription is likely not sufficient to prevent PCS, but our results suggest prescribed early light exercise should be encouraged as tolerated at ED discharge following mild traumatic brain injury. I just want to finish up by saying thank you to my co-investigators who put a lot of work into this trial, and thank you to SAME for this opportunity to present, albeit virtually. And I wish you all well, and please stay well amidst the COVID-19 pandemic.